It's now my great privilege and pleasure to introduce the Clinical Endocrinology Trust Visiting Professor for 2015. And it's a friend and colleague from the United States of America, Professor Richard Auchus. Richard has spent the last week or so visiting a number of centres in the UK, but it's good that he's visiting Scotland last. He's a graduate in bachelor's degree of Massachusetts Institute of Technology. He graduated PhD and MD from Washington University and then went on to carry out postdoctoral training in San Antonio, Texas, where he was also part of the US Air Force Medical Corps. He had pediatric training in the University of California, San Francisco, and then went to the University of Texas Southwestern at Dallas. At that stage, Richard became a full professor. And a number of years ago, he then moved on to Ann Arbor, Michigan, to the Division of Endocrinology and Metabolism. He is now Professor of Pharmacology and Medicine. He is the Fellowship Director for the division. But in addition, he is a man who is a true polymath. He has published widely on a number of aspects of steroid metabolism, steroid synthesis across a range of disorders, including hypertension, obesity, metabolic syndrome, infertility. His research is truly translational. I was somewhat humbled to note that he's also a triathlete, although I think you might have guessed that from his body morphometry. He represents still Ann Arbor University in the Masters swimming team. And I'm pleased to note he also plays golf. So without further ado, if I can invite Richard to address this evening's topic as the visiting professor. Richard.
Thank you, John. Thank you, everyone. So when I first got the email about this award, I said, sorry, you made a mistake. This is Rich Auchus in Ann Arbor. You got the wrong guy. And they said, no, you're the one that we want for this. And so as I learned about the people that preceded me, this is indeed a great honor. I'm humbled by this award. I've been delighted to spend this week with many of my friends and new friends throughout the UK. You've been very gracious, and I've had a great time. I want to address not only the work that we've done in this field, but I want to also use this as an opportunity to motivate the young people, the trainees and the young investigators in this audience to think about where we've come from and where we're heading and what still needs to be done in this area. So these are my disclosures. And where did it all start? Well, of course, it started in Michigan when Jerome Kahn identified a 34-year-old woman with hypertension and low potassium, and he had been studying the acclimatization to hot and humid environments during World War II. And so he was aware of sodium retention and the fact that there must be a hormone which was called electrocortin at the time. And he suspected that this woman had a tumor that was making autonomous production of this hormone. And he convinced a urologist to explore the patient. There were actually two teams that operated, one on the right and one at the left. And fortunately, the one on the right found a 15-gram adenoma, and Kahn describes jumping up and down in the OR and screaming with delight when this tumor was removed, and he told the people on the left, you can stop now, I think we're done. And in fact, the patient was cured. Now, what's also interesting is this photo of Kahn where you see that he's smoking a pipe in the presence of these organic solvents. I don't think that the university environmental safety people would be that thrilled of that, but at least he's wearing safety glasses. So in 1955, this is where we stood. The tracks were being laid, but the frontier was nowhere in sight. And so where have we come in mineralocorticoids and hypertension today? So that's what I'm going to talk about, and I'm going to start with aldosteronism. And if you want to start a fist fight at a hypertension meeting in the United States, you argue about how common primary aldosteronism is in the population of hypertensives. So Kahn said it was 10%. The nihilists will say it's 1%. The truth, after many studies have been done, is probably between 5 and 8%. It's certainly higher, at least 10 and probably closer to 20% in patients with resistant hypertension. And what I always point out is that even if it's only 1%, which nobody will argue with, it's still a huge problem. At 1%, that means there's about 600,000 cases in the United States, and every endocrinologist should be inundated with these patients. But we're not, and that's because it's estimated that less than 1% of primary aldosteronism patients are ever even screened, ever even considered for the disorder. And then what I want to show you in the latter half of the talk, that despite the numbers here, and this doesn't even meet criteria for a rare disease in the United States, but despite that, that primary aldosteronism is only the tip of the iceberg. So the key points I want to make is that it is the most common cause of secondary hypertension, that there is disproportionate end organ damage to the kidney, renal insufficiency, to the heart, atrial fibrillation, premature death. And of course, the reason for pursuing it is that it is curable with surgery in some cases, or managed with targeted therapy using mineralocorticoid receptor antagonists. But as I said, there are low rates of screening and diagnosis, and I think that's largely because the fear and confusion about the workup. So I want to review some advances that we've made in the diagnostics, in the mechanism of the hypertension, and in the pathogenesis of this condition. So these are the Endocrine Society guidelines that have been recently updated but not yet published. So they recommend using the aldosterone-renin ratio for case detection, confirmatory testing, and just like we do in most other endocrine disorders, confirming the biochemical phenotype before moving on to imaging. And the problem with primary aldosteronism, as is the case in ACTH-dependent Cushing's, is that because there is a high frequency of incidental masses in the adrenal glands, that if surgery is desired, that adrenal vein sampling is an essential part of the evaluation. And so I call this part of the evaluation the point of no return, because that's where you go from hundreds of dollars to tens of thousands of dollars, and you really can't turn back if you embark on CT scan. You've almost committed the patient to venous sampling. So what's the problem with that besides cost? Well, part of the problem is that it's a difficult procedure, that you'll read that there's a 20 to 25% failure to cannulate the right adrenal vein because of its unique anatomy. So the truth is that the success rate is 0% in a lot of places that don't do this regularly, but up to 95% in centers like our own that does this on a regular basis. And part of the reason is that the right adrenal vein comes right off the inferior vena cava, so it's very difficult to get a catheter in there. Second, there is anomalous anatomy or drainage that occurs with some patients. Third is that large tumors can distort the vetograms and make the radiologist confused about where the right adrenal is. As we've heard in the last talk, there can be co-secretion of cortisol by the tumor. I think this is unrecognized, and this will actually screw up the calculations that we use for lateralization. And then finally, there's discordant protocols and criteria used for the sensitivity index, which is the cortisol step up to the adrenal veins to let you know that you got the catheters in the right place. And then for the lateralization index, which is the right to left cortisol-corrected aldosterone concentration that tells you which adrenal gland or glands the aldosterone is coming from. So we've done a little work on trying to improve these parameters. So we introduced a rapid cortisol assay when I was in Dallas, where we would send the initial samples to the lab to have them measure cortisol in about a 30 to 60 minute turnaround time. And we sent the patient up to the recovery room, left the sheaths in place, and then if the cortisols were not elevated in the adrenal vein samples, we would bring them back down. It would take very little time to resample because the patient was already prepped. And if the cortisols were high, then we removed the sheets in the recovery room and went on with our business. So before we did this, we were batting about average, about a 75% success rate. And after we introduced the sample, the rapid cortisol assays, our success increased to about 98%, 97%. We actually then studied another subsequent 30 cases to make sure that this was not just a learning curve. And in that next 30 cases, we also had to resample 3 times. So in other words, we reached a plateau. We were only about 80% successful, and that's just the norm. But then consistently following up on that, about 10 to 20% of the times we would have to resample. Now, there was a smaller series that was done in Italy before us. Subsequent to this, has been reproduced in Germany, in Seattle, in Virginia, and I think this really is the standard around the world now. The only question is, how quickly can you do it? Our collaborators in Kanazawa have developed a small kit and a little machine to do like 6 to 8 minute turnaround times for cortisol, and the quicker we can do this, the better. So, to work on the problems with the lateralization index, when there is a high gradient, we have no trouble, but we often get these intermediate gradients in the 2 to 4 range, and then we really don't know what to do. So one idea we had was that we built upon the fact that there is a large literature that the immediate precursor to aldosterone, 18-hydroxycorticosterone, is particularly high in patients with aldosterone-producing tumors. And if there was some unique production of this intermediate in aldosterone-producing tumors, the place where you want to measure it is in the adrenal vein samples. And so we did that experiment, and there were 2 possibilities. One is that the aldosterone-producing adenomas make a lot of both 18-hydroxycorticosterone and aldosterone, and the other was that there was disproportionate production of 18-hydroxycorticosterone to aldosterone. And so it turns out that it's the latter reason. There's always about a 2-to-1 ratio of 18-hydroxycorticosterone to aldosterone on the side draining an aldosterone-producing adenoma, and this number is very tight. It's 2 plus or minus about 0.5, whereas the contralateral side, because 11-hydroxylase also makes a little bit of 18-hydroxycorticosterone, the ratio is actually increased because of the suppressed aldosterone production, the suppressed aldosterone synthase. Patients with bilateral disease are somewhere in between. So we can use this as a secondary criteria in difficult cases or cases where we fail to cannulate the right adrenal vein. So now let's move on to mechanisms of the hypertension. Now you're all saying, well, I know the mechanism of hypertension. It's activation of sodium reabsorption in the distal nephron and volume expansion. But that doesn't explain everything. There's often a phenomenon where patients have a blood pressure response after surgery that's immediate, but then a more sustained and gradual decline over the months afterwards. And that could be explained by readjustment of the sympathetic nerve activity. In rats, if you infuse aldosterone into the cerebral ventricles, you can cause hypertension at levels that don't even raise the peripheral circulating concentrations of aldosterone. So Andrew Kontak, von Patenassen, and my colleagues in Dallas measured sympathetic nerve activity in patients with primary aldosteronism, and you see that the levels were elevated compared to normal tensive patients and pretty similar to that in patients with essential hypertension. And then following adrenalectomy, the sympathetic nerve activity declined in parallel with blood pressure. So there's 2 reasons for the hypertension in primary aldosteronism: a peripheral effect and also a central effect. And this also might be part of the reason, in addition to the co-secretion of glucocorticoids, for the adverse metabolic phenotype in patients with primary aldosteronism. Now, unless you've been asleep for the last 2 years, you've probably heard that ion channels are all the rage in primary aldosteronism now. Started with Rick Lifton's demonstration that KCNJ5, the outward rectifying potassium channel, is mutated in patients with familial hyperaldosteronism type 3 and in a high percentage of somatic mutations in tumors causing hyperaldosteronism. And then Felix Boischlein and his colleagues and Morris Brown have found ATPase mutations and calcium channel mutations. And the final common pathway is either depolarization of the cell or directly calcium entry, and that calcium entry is what drives aldosterone synthase production. So if that's all there is, then how do you explain this case? So this is a 51-year-old man with resistant hypertension, hypokalemia, a very elevated aldosterone and suppressed renin. He has a CT scan that shows a 1.5 centimeter right adrenal mass and a normal left side. He goes to adrenal vein sampling, and he has markedly elevated aldosterone on the right side. So if you look at the right-left cortisol-corrected aldosterone ratio, they are markedly elevated. There is contralateral suppression on the left side compared to the inferior vena cava. I think everybody in this audience would send this man to surgery, which is what we did, but he still has primary aldosteronism after the surgery. Now, it's not as bad, but he still has primary aldosteronism. So how does that happen? Well, a clue came from when Bill Rainey used Celso Gomez-Sanchez antibody against aldosterone synthase to look at normal adrenal glands. And you know, most Americans haven't made aldosterone in 20 years because of the salt content of our diet. And when you look at normal adrenals, there isn't a nice zona glomerulosa like it shows in the textbook and like you see in rodents. But instead, you see these clusters of cells that are positive for aldosterone synthase. And some people have a few, and some people have a lot. And if you look at the genetics of these groups of cells, which he likes to call aldosterone-producing cell clusters, they have mutations in the same genes that are involved in primary aldosteronism, except for KCNJ5. And when you do cluster analysis of gene expression, they look very similar to the zona glomerulosa. In fact, they look more like the zona glomerulosa than the zona glomerulosa itself in their expression of aldosterone synthase and related proteins for aldosterone production. And so that leads to a model that these initial mutations may lead to these aldosterone-producing cell clusters, and then possibly the acquisition of either KCNJ5 or other mutations allows formation of an adenoma. But instead, if you just accumulate a lot of these mutations, you might get bilateral disease. And in fact, you might get both, because you may have a lot of APCCs on both sides, and one of them decides to become a tumor, or you can have an intermediate amount of these cell clusters. So there could actually be a spectrum where you could be in between normal and IHA because you just haven't quite developed enough mass. So to build further on this, the aldosterone-producing adenomas really are not tumors of the zona glomerulosa. And if you compare the transcription profile of aldosterone-producing tumors and cortisol-producing adenomas, the difference really is in aldosterone synthase. You get low expression in the cortisol-producing adenomas compared to the aldosterone-producing adenomas. But look at this. They also express 17-hydroxylase and 11-hydroxylase. They're not supposed to do that. That's supposed to be in the zona fasciculata. So these tumors are not quite like the zona glomerulosa. And if that's true, if they're making both 17-hydroxylase and aldosynthase, they should be able to make these hybrid steroids that we used to associate only with familial hyperaldosteronism. And so we can develop mass spec profiles now to measure all these steroids at the same time. And Fumi Sato from Japan has done that, and he's looked in particular at 18-oxocortisol that gives a good discrimination between aldosterone-producing adenomas and bilateral disease, but still not perfect. We're still not there yet, but it's certainly better than aldosterone or the aldosterone-renin ratio. And then finally, if you look at the tumors themselves, either histologically, you see heterogeneity of the cell morphology, and you see heterogeneity of expression of these enzymes. So aldosterone synthase is only expressed in this part of the tumor, and 17-hydroxylase is mainly in the other parts of the tumor. So the tumors themselves are not a single cell type. So if I were to have an agenda for primary aldosteronism, I would say we need to get patients screened. So everybody needs to get the word out to the primary care doctors to screen patients. To develop better methods for triaging patients who need CT and adrenal vein sampling, to develop secondary criteria for venous sampling, to develop biomarkers of mineralocorticoid action to ease the workup and to help us to titrate the medical therapy, and then to understand the heterogeneity and to pursue this mild phenotype and to understand who those people are and how we should manage them. All right, so you could spend a career studying aldosterone, and many people have. But to segue to the last third of the talk, I want to ask you, what do you do if you have somebody with resistant hypertension who doesn't have primary aldosteronism? Well, you treat them with spironolactone is what you do. And this is data from David Calhoun's group in Alabama or from the Ascot study, and you see 25 millimeter blood pressure reductions in people with resistant hypertension on spironolactone. There is no other drug in the formulary that can do this. Now, how can this be, this clinical conundrum that if aldosterone is implicated in no more than about 10% of hypertension, but aldosterone antagonists like spironolactone and eplerenone are effective drugs in up to 60 to 80% of unselected hypertensives, that it's independent of plasma aldosterone and it's particularly effective in resistant hypertension. So if we look at the pie of hypertension, we have these rare monogenic forms that account for maybe 1 or 2%. We have primary aldo, and we're never going to get this more than about 10%. And so what we've tried to do is to take this big part of the pie and either try to push some of that into this monogenic form or to divvy this up into certain other causes. And that's what I'm going to spend the rest of the time on. So stepping back and thinking about mineralocorticoids, it's not just aldosterone because it's deoxycorticosterone or DOAC, corticosterone, and cortisol that are all mineralocorticoids. We've talked about aldosterone, but DOAC causes the hypertension in 17 and 11 hydroxylase deficiency and in rare DOAC-secreting tumors. And of course, cortisol and Cushing syndrome, the apparent mineralocorticoid excess syndrome, and licorice ingestion. So my favorite disease is 17-hydroxylase deficiency, and the block in 17-hydroxylase here cuts off cortisol, androgens, and estrogens, and the lack of negative feedback drives the steroids the only way they can go, which is like the road in adrenal to deoxycorticosterone and corticosterone, which volume expands, suppress renin, and suppress aldosterone. So it's non-aldosterone-mediated mineralocorticoid excess that is ACTH dependent. So Claudio Cater and his colleagues in Brazil had been collecting patients. Several years ago, Marivanya Costa Santos brought the DNA to Dallas, and we sequenced the DNA on 24 of these patients and found that most of them had these two previously undescribed mutations, W406R and R362C, which Marivanya showed was completely inactive. Now, they did a smart thing, which is that they took blood and DNA and blood pressure measurements on their first-degree relatives. And in the parents, we confirmed that, that they were heterozygous, that 60% of them have hypertension. And in the siblings, of the 45 that we genotyped, 16% have hypertension at an average age of 31 years old. And of all the relatives with hypertension, 96% of them are heterozygous. And I think that leads to the inescapable conclusion that heterozygosity for 17-hydroxylase deficiency is a risk factor for hypertension. And if you didn't know that they had a relative affected, you would just think that they were primary hypertension. If you look at their DOAC and corticosterone, the heterozygous have about twice the level, either at baseline or with cosentropin stimulation. If you look at their urine metabolites of corticosterone, they're about twice the normals, but not nearly as high as the homozygous affected patients. And if you look at tetrahydroDOAC, again, it's about twice as high as the wild-type relatives. And these are levels that if the DOAC was aldosterone would be certainly in the range of causing primary aldosteronism. So you might say that I'll never see a patient with 17-hydroxylase deficiency or even a heterozygote, but you will see this. This is abiraterone acetate, which is an inhibitor of 17-hydroxylase, which is approved both in Europe and the United States for the treatment of prostate cancer because it lowers testosterone in men on medical castrations from low to zero very effectively. And in these patients, if you look at DOAC and corticosterone from baseline to on treatment, they have marked and profound elevations, and they get hypertension and hypokalemia unless you treat them with mineralocorticoids, which then brings these levels down close to baseline. I'm sorry, unless you treat them with glucocorticoids, usually prednisolone, but alternatively dexamethasone. And then finally, in GWAS studies, what's the gene that tends to show up? It's CYP17. So for all these reasons, I think there's an undercurrent that we're neglecting DOAC as a cause of hypertension in the general population. So then finally, let's talk about Cushing's. Now, if this lady walked into your office, many of you will recognize this is Minnie G. This is Harvey Cushing's original patient. I think any of you could make the diagnosis. She has all the common features: obesity, glucose intolerance, dyslipidemia, hypertension. We can add disproportionate supraclavicular fat pads, dermal atrophy, proximal muscle weakness, osteoporosis. But you know, these are nonspecific features. And when you look at patients with mild adrenal cortical excess, and I'm not going to use the term subclinical Cushing syndrome because I do not think it is subclinical, up to 90% of them have hypertension, about a third have impaired glucose tolerance, there is a greater prevalence of high triglycerides, unfavorable cardiovascular risk profile, unexplained low bone mineral density. And as you heard from the previous talk, it's probably not just cortisol. You know, these tumors are dirty. They don't completely replicate any one zone of the adrenal gland. And I think that we should think them as polyhormonal tumors, and that cortisol is just one of the mediators. But nonetheless, we took a series of 9 patients when I was in Dallas who had, in addition to some subtle biochemical evidence, some clinical features that were concerning. And when we removed their adrenal tumors, we found that among the things that got better the most was their hypertension, that 75% had a significant improvement in their blood pressure. Now, that work has been replicated by 2 groups in Italy in a much larger and better series. First, the Taniato study, where they had normalization in blood pressure after adrenalectomy in a quarter of patients, improvement in over a third of patients. And then finally, in the Chiodini study, which is was actually a randomized controlled trial, with some limitations, but still nonetheless, if you look at all these parameters, the ones that improved the most was the blood pressure. So these are patients with subclinical hypercortisolism that had adrenalectomy, and these are the ones that were left untreated going from baseline to post-op. There's a 12 millimeter reduction in systolic blood pressure. There was actually an increase in blood pressure in the untreated controls. So I think there's no question that this subclinical cortisol excess is associated with hypertension, although I'm not sure it's just the cortisol that's doing this. So using the iceberg analogy, I didn't know Vivka was going to show this very same image, but when we think about these rare diseases that are far away on the top of a mountaintop, hypokalemic primary aldosteronism and adrenal Cushing syndrome, under the surface of the water where the sharks are circling, there's the bigger burden, which is the primary hypertension, the metabolic syndrome, and that these incidental adrenal nodules are not all incidental. The challenge is in deciding which ones are causing the disease and which ones aren't. And I think that's where we need to get people involved in the future studies. So where are we now? Well, the railroad's been built, but the frontier is still nowhere in sight. There's still a lot of work that needs to be done. We now have some of the tools to explore this further: mass spectrometry, genomics, and other techniques. But I think we're still far, far away from the other frontier. And I want you to think of adrenal hypertension as a continuum. There's the classic disease, classic primary aldo, adrenal Cushing's, adrenal cancer. There's the non-classic disease, the heterozygotes, the mild Cushing disease, this early primary aldosteronism that doesn't meet strict criteria. And then there's probably other conditions. There may be mineralocorticoids we make that we don't even know about. There could be xenobiotics that activate the mineralocorticoid receptors. There's a large literature about GALFs, these glycerotinic acid-like factors that might potentiate the action of cortisol and corticosterone at the mineralocorticoid receptor. And we've only started to scratch the surface of a lot of these conditions. So I'd like to finish with a quote from Albert Einstein that everything should be made as simple as possible, but not simpler. And I think we've realized that we've gotten as far as we can with the simple model, and now there's the complicated problems that are up for grabs. I've had the great honor and privilege of working with a number of very brilliant and talented people over the years, both in Dallas and now at Michigan, in particular Bill Rainey and my colleagues that work on primary aldo. And these are sort of arbitrary categorization because most of these people work on multiple things. Of course, Claudio, Marivania, and Cedric and Maury for the work on CYP17, our work on mild cortisol excess with Fiemo, my main surgeon, our study coordinators in Michigan, and our funding agencies. I also have to thank my teachers, my mentors throughout the year, Walt Miller, Suzanne Fuqua, Chris Walsh, Rick Danheiser, and others. And then finally, I need to thank my parents, my brother Alex, and my family. This is my wife, Mary Lou. Today's our 25th wedding anniversary, and she was supposed to be here today, but because of these other rascals, she couldn't come. This is my daughter Nadia, my other daughter Gabriella, my son Greg, who likes to dress as a chicken sometimes. And I really thank you for staying to the end of the day. This has been a great honor and a joy for me to be here in this wonderful and historic city to present these data to you.